Going to bring up our keynote speaker to give us a glimpse into the future. Dr. Brent Myers is an internationally recognized expert in EMS and mobile integrated healthcare. His areas of expertise include evidence-based performance measures, system design, care for the patient in cardiac arrest, and population health management. For over 12 years, he has served as the medical director for Wake County EMS System in Raleigh, North Carolina. He is president-elect of the National Association of EMS Physicians and now serves as the Chief Medical Officer and Executive Vice President of Medical Operations for Evolutions Health, as well as Associate Medical Director Officer for American Medical Response. He also serves on the editorial advisory board of EMS World's sister publication, Integrated Healthcare Executive. Please welcome Dr. Brent Myers.
Good morning. It's nice to be back with a great group of friends, seeing folks that I haven't seen in a long time. I want to apologize up front to the really close friends who just lost the over-under bet over who was going to be at the Martini Bar first today. So I apologize for that. I tried. What I'd really like to do over the next little bit is talk about where we are and then more importantly, where we need to be. And this talk a year ago would have been theoretical. This talk a year ago would have been, well, let's think about how the world might be. My hope over the next few minutes is to convince you that this is how the world is, that this is not a theoretical conversation, that the change that we're going to talk about over the next few minutes is happening as we speak, literally as we speak, and that we need to be ready to move forward with it. So I have one disclosure to make, which is I have gone all in on this mobile integrated healthcare thing. This is what I do for a living. So from that purpose, I do have a conflict, because if this doesn't work, I don't make a house payment. So I'm conflicted in that way. Yogi Berra started this the right way. When you come to a fork in the road, take it. Now, people kind of take that tongue in cheek sometimes, but I think it speaks exactly to where we are today in EMS. We are no longer at the point where we can have one path. We have come to the fork in the road, and over the next few minutes we're going to talk about two forks. One of those is responding to traditional emergencies. And I'm happy to tell you that we've still got to be good at that. And we're going to talk about that for a little bit. But the other side, the other fork in this road, is that we have to take care of populations of people. We are the best set in every community to be able to take care of populations of people. That's our design. We're ready to do that. The part about this quote I think is most important is take it. Meaning we no longer have time to stand at the fork and pontificate about how we might move forward. Paralysis by analysis will get us. We've got to move. And so I'm hoping by the end of this talk, you'll feel comfortable not only taking care of emergencies, but moving into this new space. So I want to talk a little bit about traditional EMS, because I think that's important, what we think of as traditional EMS. But then we're going to talk about how it is that we make decisions, because I'm going to challenge the way that we have been taught that we make decisions. We'll go off the beaten path for just a little bit, and then we'll come back to how the future should look. And somewhere along the way, we'll get to make fun of Ed Rock, so that'll be good. So, this statement has to be made, because in today's environment, we can erroneously become too focused on this notion of mobile integrated healthcare, caring for the community and population, how do we keep people out of the hospital, and forget that emergencies actually still happen. And we have a moral, ethical, legal responsibility to respond to those in the best way possible. So emergencies still happen, and we have an opportunity to make a difference. And I'm just going to hit a couple of highlights of the traditional EMS world. The first of those is this notion of cardiac arrest. And it has been frustrating for some that over the past 40 years, this has been the measure by which many EMS systems are judged. I would give you the hypothesis that it's okay that this is the measure, because in the absence of us, people do not survive. This is the measure of how we do, because we are the only people that can impact this outcome. So if we look at the CARES registry across the country, we now can measure in the same way in multiple communities. And what that allows us to do is set benchmarks across the country and say we make a difference. And our Heart Rescue Project partners utilize this CARES data and challenge communities to double their survival. And in point of fact, they did. Communities have doubled their cardiac arrest survival simply by paying attention to traditional EMS maneuvers. So if it's not worth getting up every morning to double the survival in your community, I don't know what is, right? This is awesome news that if we just pay attention to what we're doing, measure it, and implement evidence, we can double survival. And that's a fantastic thing. And then I'm going to go back just a little bit in history to the Opals Project. And looking around the room, I realized there's some folks that started EMS after all this research was done. So I apologize for those that have already heard it, but for those not in the room when this was done, in Ontario, when they went from BLS to ALS, the governmental providers said, does it matter? Does putting a paramedic in the truck actually help? And study after study said, well, we can't tell, we're not sure, and then Opals comes out. And what they learned is, let's take respiratory distress, for example. In every respiratory distress patient to which we respond, we save a life every 50 times. Save a life. Now, people say 50 is a big number. Well, 50 is a big number if you're talking about 1 day less of toe fungus. 50 is not a big number if you're talking about saving a life, changing that outcome. So once every 50 times we respond to respiratory distress and follow evidence-based guidelines, we save a life. So traditional EMS matters. So I don't want anybody to take the rest of the talk and go, well, they talked about everything but 911 response and what we do doesn't matter. It absolutely does. However, we're at that fork in the road, and we're going to have to embrace another component of healthcare going forward. So, how is it that we make decisions in EMS? And I find this fascinating. I'm not going to get into the educational theory argument other than to say the greatest disservice in EMS education that's ever been done is this notion that paramedics and EMTs don't make diagnoses. I've always found that humorous. You go to a scene, you assimilate a history, a physical exam, and take ancillary data, and then you treat somebody based on what you find. If that's not making a diagnosis, I don't know what is. And so we get that notion, and then we have a difficult time making decisions. Because we are told that we didn't make the diagnosis, we looked at a constellation of symptoms. And in so doing, we provide a disservice to our communities. Now, I'll get to why I think that's true in just a moment. So the first thing in true decision-making processes that we need to think about is what is the risk-benefit ratio of our activities? And here is the kind of take on this. How many times have we heard, well, just take them to the hospital, that's the safest thing to do. That will mitigate your risk. People say that all the time. How many people a year die in hospitals due to medical error? 100,000 at a minimum. Some would say 200,000, depending on how you measure it. I would argue that if we went to the public and said, where we're going kills 100,000 people by accident every year, get in the van and go with us, many folks might go, you know, is there another option? Is there something else that we can do? And so the first thing we have to do is have an honest discussion about risk and benefit. And there is some benefit in going to a cardiac cath lab with a STEMI, that's probably true, but I'm not sure there's benefit in going to the hospital with a fever, necessarily. And we'll talk about that in a little bit. So this diver, right, looks at risk-benefit and says, I personally have a fairly low chance of getting hurt on this particular dive, but I have a lot of reward immediately because it's fun to jump. Right? That's how people think about risk and benefit. It's what you can touch versus the theoretical. So if we could take all the cars off the road, I would, without a helmet, with a fifth of tequila, ride a motorcycle every day. I would. because I think that would be fun, and I'm willing to take on that risk. But when we put ourselves as population health providers, we don't get that luxury. We can't get on a motorcycle drinking tequila every day without a helmet because we hurt the responding public. The same thing is true when you respond lights and siren in your ambulance, I would argue. That moving lights and siren through the community, while it may give you an immediate I'm getting there faster feeling, we are actually putting the driving public at risk. When we do that, members of our community are twice as likely to be injured in the accident as we as the EMS professionals are. So we can't, with a risk-benefit ratio, say, well, we're not sure, so we'll just go lights and siren to everything. Oh, we're not sure, we'll just take everybody to the hospital. The risk-benefit ratio doesn't work. And the part that this diver doesn't want you to see is the head-splitting video. And if you haven't seen that, watch it on your own time. I'm not going to show it here. It's quite impressive when you hit your face on the diving board. But then we move into trying to talk to patients about their own risk. And this is where the world gets very difficult. This is 1 million people engaging in whatever the activity is that's listed, and then what the outcome might be. So it takes 1 million people to smoke 1.4 cigarettes to have 1 case of lung cancer. That's kind of a hard risk thing to help patients get their brains around. It takes 2 months living in Denver for 1 million people to get cancer from radiation. Is that really true? Chris Caldwell's here. I don't know. Are they dying off at that rate? I think the problem when we talk about risk is that it's difficult for us to understand it, and then it's very difficult for us to explain it to our patients. And what I'm going to posit to you in the New World Order for us to have sustainability is we've got to get better at this. And there are better ways to communicate risk than the traditional health risk. So, I know this would never happen in your EMS system, but in some EMS systems, I have heard that when you get really close to shift change, there's this ability for patients not to go to the hospital. That somehow they're well enough to stay at home right before shift change so that we can get back to the station. Now, again, it doesn't happen in your EMS system, but I've heard it happens in some. The interesting part of that is we should quit doing this as the off thing and embrace it and use some science and say it's perfectly okay for you not to go to the hospital at the beginning of the shift, at the middle of the shift, as well as at the end of the shift. Because we have some evidence to support that. One of the problems that we have is a paper by Lawrence Brown, who I love, great guy. He just assembled the data that were there. But the problem is this paper has been quoted over and over again when it comes to decision-making capabilities of EMS providers. And this paper was in 2009, and he assembled the literature about can paramedics safely decide who needs to go to the hospital? Can you really make that decision? Is it possible to put that risk-benefit ratio and have a conversation with patients? And what they found is that there are only 13 papers in the literature that looked at it. So that's number one. Not a whole lot of robust literature about this question. The second thing that they found is that the outcomes were variable. In other words, what made a right decision about leaving somebody at home? And in the vast majority of these studies, it was the patient admitted to the hospital? So if the patient was ultimately admitted to the hospital and the paramedic didn't take them in the ambulance, then that was a failure. Now, I don't know about your community, but what's in the literature suggests, and in my experience suggests, the admitting threshold of emergency physicians varies threefold. Depending on who's sitting behind the desk, and we all kind of know this, some admit everybody, some admit none, and some admit kind of in the middle. And we're judging your decision making against that variable. That's just not fair. That's just not a way to look at things. So in the one study that was included here, this one from 2000, where they actually looked at objective outcomes with a predetermined protocol set. When they did it that way, what they found is, these are the actual outcomes, so it's just trust me, they were objective. 97% were appropriately categorized by EMS professionals. And of the 7 that were missed, 6 of those was a misapplication of the actual protocol, so the protocol only missed 1. And the only one that it missed was somebody that had one episode of hypotension after they hurt their knee. Probably would have been okay to go to the hospital some other way or the clinic or wherever they wanted to go. So the point of all of this is that if we give good evidence, solid education, give you decision-making capacity with a risk-benefit ratio around it, you can safely decide who needs to go to the hospital and who doesn't. That is perfectly within the scope of practice, and the evidence supports that. The problem is we go back to those other studies that compare you to the variable emergency physician, and we put them all together, and this is the slide that everybody remembers from this paper, which says at the bottom we missed 10%. And that's not acceptable. I would argue with you that we can stand up with solid evidence and say we are capable of making the decision about who needs to go to the hospital and who doesn't. And that's the first step into our sustainability into the future, I would argue with you. So, if you have not read, I encourage you to read this book. It really helps us understand how human beings make decisions. So part 1 is we have the capacity to make decisions about who needs to go to the hospital and who doesn't. Part number 2 is how do we communicate that to our patient? What is it that we say to our patient to communicate that in the appropriate way? And my favorite statement about this is, well, we just provide the information and the patient makes their own decision. Well, that's true, except the way that we give that information, the descriptions that we put around it, the options that we give the patient change the decision they're going to make. And this is not being paternalistic. This is not saying we're going to tell you what to do. This is just acknowledging the fact that decisions are made in different ways by different people. So when we look at this book, one of the examples that they use is the cafeteria line. And in cafeteria line A, you have fruits and vegetables and good food in front of you. You have the independent decisions you want to make, but you go here. In B, you have all the fried food that you want. Independent decision, entirely different process. This was actually studied in school cafeterias. And literally the height and movement of placement of the French fries determines their consumption to a great extent. French fries are always available, just depends on where you put them. And if you think about your interactions with families, patients, caregivers, other healthcare professionals in the middle of the night, you can see the equivalent of making these explanations to your patients. Where do you put the French fries? That helps you help your patient get to the right decision, and that is part of the sustainability of the future. Emergencies happen, but we're going to be helping navigate and make decisions, and this is kind of the background of that. So that's kind of a wondering introduction to get to part 2, which is how do we actually do this? And this is where a year ago I would have had to stop the lecture right there, because that's just theory and that's the way it is. Over the past year, however, Secretary Burwell of Health and Human Services has said the following. In 48 months, 60 to 80% of the Medicare spend will be on value-based purchasing. What the heck does that mean? That means over half of the money that Medicare doles out will not be for fee-for-service. It will not be paying you for an ambulance trip to a hospital. It won't pay for the individual visit. It will be, did we make the patient better? And my argument to everybody in this room is that we, more than anybody else, are set to implement this plan. We're already ready to do it. We've just got to drag everybody else with us, but we're ready to do it. Because we want to take care of the population. We don't care about the fee-for-service run. So this is not theoretical. This is published, New England Journal, going to happen. So as we try to implement this new world, this value-based world where we actually get to take care of people rather than do procedures, there's a lot of fun that comes in the EMS side, and that's what I want to talk about for the next few minutes. So the first is, in this very state, this is no longer theoretical. Again, couldn't give this talk a year ago because we would have been talking theory. This bill is passed. For those of you that live here, you know. And what this bill says is we now recognize community paramedicine. We now recognize that EMS providers are going to be making decisions about who goes to the hospital, who doesn't go to the hospital, what clinic they go to, whether they stay at home, already in law. So this is not, an ethereal thing. This is actually happening today, right now. These decisions are part of who we are. So why would hospitals care? And if you have not been to hospitalcompare.gov, you ought to go, because it is one of the most entertaining sites you could ever read. And I've got some measures here that really matter, and I've got some others that are like, why are they measuring that? Just because it's fun. So let's talk about the way this site works. You go in and put your zip code in. So I put in the one for my house in Raleigh. And we went through, and there's Rex, which is part of UNC. There's Duke, which is obviously part of Duke. And then there's Wake Med. Now, you know the folks at UNC and Duke don't even speak to one another on any circumstance. And so there's all kinds of competition between these facilities. This is available publicly today. So let's just see what they're reporting. Number one is they are reporting the average time to pain medication if you arrive with a fracture. You're like, Myers, what does this have to do with EMS? Well, those of you that are thinking fast, you're already there. I'm going to get there in just a second. But look at our good friends at Duke. Now, I'm a Chapel Hill grad, so I can make fun of Duke all day. But look how long it takes to get pain medicine if you have a broken bone at Duke. What if you were the Duke quality person? What would be the first thing you would ask? Will you let me count EMS pain medication so that I can get my time to zero on the patients that come in via EMS? Can EMS help the hospital meet their goal? Take care of the patient, do the right thing? Clearly they can. I will tell you my hypothesis, and this is a conversation we've had publicly, so I can have it publicly again. There are 2 physicians at that Duke receiving ER that give our medics the business every time they give pain medicine. And that's their attitude, and it is now translating to a slide in front of CMS. My guess is pain medicine is going to flow like water at Duke after this, right? Because they're not going to let that sit like that. So here's one that we really can impact. COPD readmissions. There's a target, right? The target is 20% down at the bottom. And you can see all 3 of those hospitals and how they perform. So in the current world order, if I'm the hospital chief financial officer and somebody goes home from a COPD exacerbation and the ambulance brings them back, I'm okay with that. Because if I got a 2 or 3% penalty, but I still make the money, most of the money, it's a good thing. Tomorrow, that penalty goes up, this gets published on the website, and all of a sudden, EMS provider, don't bring them back to the hospital because their nebulizer's out. Drive down to the pharmacy and get them the stuff and bill us back for it. If they can't take their own steroid, would you mind driving out every morning and just giving them their steroid for their 5 days so they don't bounce back so I don't get on this? All of a sudden, there's an alignment. There's not the, you are out there, we are in here, because they have to control this, and we bring these people back to get them readmitted. So these are serious ones. This one is just amazing to me. Random fact. Who gets an MRI for low back pain? And they just report that out. I don't know what you're supposed to do with that information, because there's nothing on there about whether they needed it or not. So we're not going to worry about MRIs for back pain. But this one matters. This one is awesome. This one looks at 2 factors about heart attacks. It says, number 1, are you more or less likely to die than the national average? And it says, number 2, are you more or less likely to cost more than the national average? So if you're the EMS provider in the community for hospitals that are held to this standard, and you've got chest pain patients that want to bounce back to the hospital, they are very interested in helping you. Right? Very interested in helping you keep these people from coming back. And this, again, is not theoretical. This is happening today. And then finally, perhaps the most important initiative during this little part of the talk that I hope everybody walks away with knowledge about is this bundled payment initiative. This was a voluntary and is a voluntary process by which you as the hospital take on the risk for the full 90 days of that patient's care. So you are responsible for that CHF patient from the time they admit to 90 days later. You can imagine the incentives that would come to an EMS agency that could go to that person's house, start an IV, give them a little Lasix, keep them from coming back to the hospital. That could make sure their blood pressure is okay. That could deliver their ACE inhibitor. You see the notion. But here's the part that people miss. They did this also for artificial hips and artificial knees. And it became a voluntary thing. And they said this is a 3-year project. 6 months in, they saved so much money, they made it mandatory. Every single hospital in the United States that puts in an artificial hip or an artificial knee today is mandated under the bundle payment plan. That changed just in the past 6 months. So the pace of change is so fast, and the hospitals need us to guide them and help them understand what we can offer by keeping these folks well and in the community. So a bundle payment plan is worth knowing about. So to recap where we are thus far, emergencies still happen. We have to be ready to take care of those. But we also need to think about different ways to engage our patients. The theories of behavioral economics, the ability to give them options besides the hospital and partnerships with others are very important. Now, I'm going to take a 2-slide, very quick diversion with your leave, so just give me just a moment. One of the roles within EMSP is that we are offering a Latin American medical director's course. We've offered these courses around the world, mostly in Asia, and we had our first opportunity to offer the Latin American medical director's course last Sunday. And last Sunday, it was in Havana. And it's not really, a life-changing experience may say too much, but a life-informing experience is not an understatement. It is incredible to see what goes on there. The highest paid physicians make $60 a month. $60 a month. Entirely different way of looking at the world. But they have something for us to reflect upon, and that is the way they have set up their health care. They have a primary general practitioner for every 1,000 citizens. They have a primary clinic. They are responsible for those folks. They give them cab vouchers, they make sure they have their meds, they do all of the care for them. And then that's supported by a polyclinic, which is in essence an urgent care. They have surgery, they have pediatrics, they have a general practitioner. They're open around the clock and have access for patients to come in. And then there's your acute care hospitals. Not all that, honestly, dissimilar to ours. The interesting part is 104 is the equivalent of their 911. Only 10% of those transports begin in the home. 90% of them begin at a primary care clinic or a polyclinic. And if we look at our data about emergencies that actually happen in the United States, what percent of our calls are actual emergencies? 10%, maybe 15% of EMS responses are actual time critical emergencies. So I'm not endorsing that we shut down and quit going to all these patients' homes. What I am suggesting, though, is that we have a very unique opportunity for that 80 to 85% to give a different option than hospital transportation. Right. All right. So let's go back to the real world. 2-slide diversion. Come back. This study from the past year, one of the most overlooked ones, I think. Very interesting, very simple little study. They did 3 things for patients with chest pain. They did a programmed, protocolized evaluation of their chest pain. They did an EKG, and they took a single troponin blood test. This was done in hospital. What part of what I just described requires a hospital? None of it. Protocolized evaluation, EKG, single troponin. And what did they find? What they found is that if you do those 3 things, and there's 2 results here, we'll do the top. Did the patient have a heart attack in 30 days? If they had a negative troponin, that bottom line there under less than 3, 0, had a heart attack. If we look at 30 days, all calls go into the hospital. Do I have chest pain? Do I need to go and have a cardiac cath? Do I get admitted for any reason? That's the MACE group here at the bottom. Only 1 patient even got readmitted in the 30 days after being negative on the scale, negative on the EKG, and negative on the troponin. Now, this needs to be studied in the pre-hospital setting, but can you quickly, I think, imagine a day where patients call you for chest pain and you can go to their bedside with decision support and leave them in their home? What a wonderful day that would be. Patients would be thrilled, right? I'm in low risk, you've done my blood test, you've done my EKG, we're done. It's beautiful. The obvious next piece of this is then to support this with telemedicine and telepresence, right? So when we cannot get to the decision-making process via a protocol, an EKG, and a blood test, we can bring in via telepresence whatever specialty might be necessary at that patient's side. Those of you know I do work with Ed Rock quite a bit, and so I asked him to kind of share with me his best telemedicine experience so that we could share that with you. And this is kind of what he sent me. So I'm not sure what Ed was doing, but strange telehealth experience. Telehealth actually is a huge piece of this decision-making process. The ability to bring decision-making support to the patient's side in real time to supplement our decision-making process will allow us to leave more patients in their home and take less to hospital that don't need to be there. And that is going to be the ultimate, if you will, of that other branch of the fork in the road. So, final thoughts of how do we get there? What is it that we do to make this happen? The first is we endorse accreditation of our educational programs. We will never be able to enter the healthcare space and say to the payer, provider, and hospital, we're going to partner with you if every single educational institution delivers a different product. Just can't do it. We're well down the road of this accreditation process, and good for us, because in the absence of this, we would never have gotten there. So that part is fantastic. The second thing is that we got to realign reimbursement. And again, a year ago, this was a theoretical conversation. But today, it's real time. Because you just saw in Nevada, it's already happened. In Minnesota, it's already happened. Tomorrow, in the state of North Carolina, they are very likely to introduce a bill that will change Medicaid to a fully capitated payment, no more fee-for-service in the state. That's very likely to be introduced tomorrow. So this is not theoretical any longer. It saves real money, $300 to $500 million a year, just by allowing EMS to make decisions. To go ahead and embrace the fact that you can tell who doesn't need to go to the hospital and you can give them other options. It takes $500 million to spend out of the healthcare spend every year in the United States. This has been described in multiple ways, and you'll note that I held mobile integrated health as a term to the end because it really doesn't matter what you call it. It is just a fork in the road, and we've got to embrace better decision-making processes. NAMT has a wonderful website with a list of resources that are available to you. If this is of interest to you, this is where you can go and find everything you need to know about implementation. It's a wonderful site with lots of resources. There's a textbook, lead authors are here, that guides you through this process. So there's so many resources available today if you really are interested and want to implement now. So what does this mean for you as the individual EMS provider in 2015 going into 2016? The first thing it means is emergencies still happen, and we have to use evidence-based care, measure it, and mitigate those circumstances. The community counts on us for that. We have to be ready for active shooter and cardiac arrest and trauma and respiratory distress and all of those things. That's fork one in the road. Fork two in the road is that we have to acknowledge it just doesn't make sense that 8% of the U.S. population needs to go to the hospital by ambulance every year. Yet 8% of the population calls us every year via the 911 line. So we have to embrace that they are using that to access health care, and a few of them have emergencies, and we've got to be good at those. But the other fork in the road is that with an professional team, we can do better. we can give those patients meaningful options and meaningful choices going into the future. So we end where we started. We are at a fork in the road. This is not a theory, this is a fact. Today, tomorrow, and the next day, healthcare policy is changing faster than it has in any of our lifetimes. We've got to still go to emergencies, but we have to get ourselves on this other road where we can give patients choice, we can be meaningful in a population value-based purchasing world, because the way the money flows is changing, and it's changing literally while we're standing here. And with that, I want to thank you very much for having me. I've really enjoyed it, and thank you so very much.